Okay, hello. Okay, so this discussion today will be about anatomical landmarks. So landmark is like something very unique that you can easily notice. For example, like when you are giving directions to someone, like you want to give some place which everybody will be easily able to identify. For example, um, some well-known place, for example, Sami Abdur Rahman Park or some place like, so you can say like it is near to that, or it is adjacent to it, opposite to it, and such things like that. So in complete denture, the landmarks actually means some things which are really very prominent and which you can easily identify in your impression or the cast which you make for your complete denture patient. For example, in the maxillary impression, you see some prominent structures. The most common one or most prominent one that you will notice is the rugae in the palate, anterior of the palate. And then also you can see the incisive papilla. This is one of the prominent landmarks which you can see in the maxillary impression or cast. And then you have something that runs in the middle of the palate, which is called mid-palatal raphe. And then this is the rugae. So likewise, like you have so many other things which you can also see from your impression or the cast. So basically we want to classify these identifiable structures into some categories. So why we have to classify this is like, so we identify a particular structure and then we do something in relation to that while making the impression or while constructing the denture or while arranging the teeth. We use these landmarks and some recommendations which are provided based on these landmarks to fabricate a denture which is more comfortable and more functional for the patient. So basically, the landmarks would be classified into three categories. The first category which I would like to mention is limiting structure. And then the second one which I would like to mention is supporting structures. And then the third one is relief structures. So limiting structures are structures which are usually considered as the end of the boundary of the denture or the border of the denture flange. So when you have a denture, you have a flange, you have a support, an impression area or tissue contacting area, and then you have a flange, and then you have the artificial teeth. So the point where the impression ends, it's called, the point where the impression ends, it will be seen in the cast as sulcus. The sulcus is like a deepened portion which lies between the residual alveolar ridge and the cheek or the lips in the anterior area. So it's a deepened area which lies between the tissues, the lips and cheeks on the outside, and the residual ridge which is present on the inside. So sulcus again is named based on the location. For example, if it is located between the lips and the ridge, it's called labial sulcus. So you have right labial sulcus and left labial sulcus. And then you have buccal sulcus, which is between the cheek and the residual alveolar ridge. So buccal sulcus is called buccal sulcus because the cheek, the muscle that forms the cheek is called buccinator. So since that's why it has the name buccal sulcus. So since it lies between the buccinator muscle and the residual alveolar ridge, it's called buccal sulcus. So between each sulcus, the labial sulcus and the buccal sulcus, labial sulcus and buccal sulcus, you have some kind of attachments which look like some kind of extensions between the sulcus. So in the anterior, you have something like a extension, which is called the frenum. Since it is present between the lips, it's called labial frenum. And these extensions that are present on the side towards the buccal surface or towards the cheek between the buccinator muscle and the residual ridge, they are called buccal frenum. So you will have two buccal phrenums, one labial phrenum in the maxilla. So labial sulcus, labial phrenum, buccal phrenum, and then buccal sulcus. In this cast, if you notice, like on one side you have two buccal phrenum, and on the other side you have a single buccal phrenum. So it is a normal variation. In some patients you will have just one on each side, or sometimes you have two on each side, or sometimes you don't see anything at all, something like a thick band, a continuous band might be seen. So it depends on patient to patient. So it is not compulsory or necessary that you should always have two frenums on one side and one frenum on the other side. So it can be one on either side, or it can be also two or one. It can be any different types. And usually sometimes it is very prominent and attached very close to the residual ridge. Sometimes it is not very prominent. It is not even observable in the impression or in the cast. So it depends. So these are the limiting structures. So limiting structures are structures or the point at which you want to stop your denture. So beyond this point, we don't want the denture to extend beyond this point, because beyond this point you will have muscles attached on the side of the jaws. So if the denture is extending beyond these points, usually it is considered as an overextended denture, and an overextended denture usually has very less stability, and it is going to get dislodged very frequently. And to complete the limiting structure on the maxilla, you also have to identify the posterior limiting posterior limit or the boundary, like this. So this posterior line, which forms the posterior limit of the maxillary denture, it's called posterior vibrating line. And you also have another line which is called anterior vibrating line. So anterior vibrating line is not a straight line, it's somehow like this. So this space which is present between the anterior vibrating line and the posterior vibrating line, it's called posterior palatal seal area. So posterior palatal seal area is an area which is present in the posterior portion of the maxilla, and in this area you have some soft compressible tissues. So when you make impression, you are going to compress this place to obtain a more perfect peripheral seal. So with this, the limiting structures of the maxilla is complete. So limiting structures again are structures which are going to limit or give you the point where you want to stop your denture. The denture flange has to stop in that point. So from the anterior we will have labial phrenum, labial sulcus on the right side and left side, and then you have buccal phrenum on the right side and left side, and then you have buccal sulcus on the right side and left side. And after the buccal sulcus, you have a small notch or a depression on both sides. This is called hamular notch. And after the hamular notch, you have an area which is called posterior palatal seal area. So posterior palatal seal area is an area located between anterior vibrating line and posterior vibrating line. So I hope the limiting structures of the maxilla is a bit more clear now. It is the same for the mandible. So in the mandible, again you have labial phrenum, a small muscular attachment which is present on the midline, and then you have labial sulcus, both on right side and left side, right labial and left labial sulcus, and then you have another muscle attachment, fibrous attachment on both right side and left side. These are the buccal phrenum. So the buccal phrenum, behind the buccal phrenum you have buccal sulcus. You have buccal sulcus here, both on the right side and left side. So there is a confusion, or one of you asked a question about what is the difference between buccal sulcus and buccal shelf. So let us imagine like we have the crest of the ridge. So crest of the ridge is the highest point on the residual ridge. It is called crest. And then you have slopes. So this is crest, and then below the crest you have slopes. These are the slopes. So in the posterior area, in the slope of the ridge, you usually have a small flat portion of the mandibular arch, which is present between the crest of the ridge and buccal sulcus. And this portion is like a shelf, and this is usually very prominent in cases where you have severe to moderate bone resorption. So when there is good bone, usually this shelf is not really very prominently seen. So in those cases which have good bone, the buccal shelf might not be really very evident. So we can also say, like, in such situations, the buccal shelf is actually non-existent. So buccal shelves begin to appear more when the bone in the posterior becomes more flatter and flatter. So when you have a more flatter alveolar ridge in the posterior, then this shelf-like area, which is present between the buccal sulcus and the ridge crest and the retromolar pad. So this is the retromolar pad. Retromolar pad is a small pad-like structure which is present in the place behind the place where the third molar was existing. So imagine you had your third molar in this place, and normally a small pad-like structure is present behind the third molar, and this is called retromolar pad. So your buccal shelf is the area which is present between four structures: the buccal frenum, buccal sulcus, retromolar pad, and then the ridge crest. So this is the small area which is present between these four structures, and this is really very evident only in cases where you have severe resorption. Imagine you have a ridge which is really tall and more rounded. Your buccal sulcus here is here, your cheek is here. So you might not have any flat ridge here, but imagine you have a flat ridge which is like this, and then your sulcus is deep like this. You might have a small flattened area here, this portion, which can actually provide a good vertical support for your denture. So buccal shelf will be evident or more prominent only in cases where there is more resorption, more bone resorption. If the ridge is more bulky and voluminous, the buccal shelf is sometimes not existing at all. But in general, this buccal shelf area is usually present in most of the cases of complete dentures, because the patients of complete dentures usually have some kind of resorption. We are not going to remove any posterior teeth unless there is like some severe bone resorption, mobility, periodontitis, or any other reason. If the tooth is firm, if there is no periapical lesion, mostly the tooth is saved and the patient might not be a candidate for complete denture. So most of the complete denture patients who come to you, they already have their molars extracted very long time back, and mostly the posterior ridge is slightly flatter, moderately resorbed. So in that case, you will definitely have a buccal shelf or a flat shelf which is present between these four structures. So ridge crest, buccal frenum, buccal sulcus, and retromolar pad. Between this small portion, this is called buccal shelf. So in the mandible, the limiting structure is labial frenum, labial sulcus on both sides, and then you have buccal frenum on both sides, and then buccal sulcus. And then in the posterior, in the maxilla, we had posterior palatal seal area, but in the mandible, instead of the posterior palatal seal area, you will have retromolar pad. So the retromolar pad is a small projection seen behind the third molar. And then in the lingual side, you have lingual sulcus. So lingual sulcus is again right side and left side. You have right lingual sulcus and left lingual sulcus. Lingual sulcus is also called as, sometimes referred to as in textbooks as, alveolo-lingual sulcus. It means like alveolo, the word alveolo refers to the alveolar ridge, and then lingual refers to the tongue. So a sulcus which is present between the tongue and the alveolar ridge, it's called alveolo-lingual sulcus. Then between the two sides, you have again you have a small fibrous attachment from the tongue to the ridge. It's called lingual frenum. So you have labial frenum, labial sulcus on both sides, buccal frenum on both sides, buccal sulcus on both sides, and then in the posterior you have retromolar pad, and then lingual sulcus, lingual frenum, and again lingual sulcus on the other side. So this is the limiting structure or boundaries of the mandibular edentulous cast or edentulous mouth. So it's the same for maxilla: labial frenum, labial sulcus, buccal frenum, buccal sulcus, hamular notch on both sides, and then you have the posterior palatal seal area. Okay, so this concludes the limiting structures for both maxilla and mandible. Now, anything that is inside this limiting structure is going to have a contact with the tissue impression surface of your denture. So your denture has two surfaces. One of them is the tissue contacting surface. The other surface is the occlusal surface, which faces to the occlusal surface of the opposite arch. Okay, so anything that is inside this limiting structure is going to come in contact with the denture, and all the forces that are going to be created in the occlusal surface is going to get transmitted to the surface which is inside this limiting structure. So all of these structures actually have to provide some kind of support during the occlusal load. But actually, like, there are some points inside these structures which might not be really very efficient or very capable of taking up all the forces. So depending on the ability of a particular area to withstand the occlusal force, we can classify them into supporting structure and relief structure. So relief structures are structures or points where any kind of force would be uncomfortable for the patient. For example, the incisive papilla area. Below this incisive papilla, you have something called as incisive foramen, which is inside the bone of the maxilla. There is a small opening in the anterior of the maxilla, premaxillary area. So this small opening gives out lots of blood vessels and nerves, not lots of blood, incisive vessels and nerves. So when you're making an impression, if this area gets compressed, the pressure is also transmitted to the denture that you are fabricating from the impression. So when the patient is using such a denture, which was fabricated from an impression that compressed this area, the denture is going to continuously apply pressure in this area. So when there is a continuous pressure in this area, there might be ischemia. So when there is pressure, usually two things can happen. One of them in soft tissue and one of them in the bone. So in the soft tissue, when there is pressure, you have reduced blood flow. So when there is a compression, when there is a pressure in soft tissue, the blood flow is reduced, and this is called ischemia. Ischemia is like a state of reduced blood flow. So this is going to cause some changes depending on whether the pressure is continuous, short term or long term. So when there is a continuous pressure for a longer period of time, this might lead to some changes which might be irreversible. So the patient might start developing numbness due to the compression of the nerves. There is reduced blood supply and also compression of the nerves. The patient is going to start having some kind of numbness in the premaxillary area, in the anterior maxillary area, which will cause a lot of discomfort. So this area, the incisive papilla area, is not suitable to take up the occlusal load. So when you make impression, you have to relieve pressure in this place so that your denture is not compressing this place, and it's going to be more comfortable for your patient. And immediately behind the retro-incisive papilla, you have a small, thin, elevated portion in the middle of the palate. It's called mid-palatal raphe. So raphe is usually like a fibrocartilaginous structure which connects to soft tissues. So you have the palatal mucosa on one side and another side. So in the middle, they meet in the mid-palatal raphe. So this raphe area doesn't actually have any submucosa. It has mucosa and then very thin or virtually non-existent submucosal layer, and then the mucosal layer directly attaches to the periosteum and down to the bone. So this place also is not very suitable for applying pressure. So this also needs some relief from pressure when you are making impression. So you have incisive papilla and mid-palatal raphe, both of them need some kind of relief from the impression pressure, the pressure which is applied during impression. So these two structures should be considered as a relief area. Apart from this, in maxilla, sometimes there might be some places where the tooth was recently extracted and maybe the bone on the buccal side is slightly projecting out. For example, mostly in the canines and premolars, they are like crossing over across the arch. They're in the corner of the arch, here and here, they're in the corner. So when the bone is projecting out and it is not resorbed, it is still healing or not completely remodeled, there is a possibility that when you make an impression, you might apply a little bit of pressure here, and this might cause a lot of discomfort for the patient when you fabricate a denture. So any bony prominences, any places where the extraction was recently completed, those places also should be considered as relief areas. So in maxilla, mostly the relief areas are the incisive papilla, mid-palatal raphe, and then the bony prominences which are present around the extraction sockets, the place where the extraction was recently completed. And also in the ridge, when you consider the ridge, you have two parts in the ridge. One of them is the crest and the other one is the slope. The slope of the ridge is usually made up of cortical bone, and it is actually resistant to resorption. But the center of the ridge, which forms after the extraction of the teeth, is usually made up of soft bone. So when there is a pressure during impression in this area, in the ridge crest area, normally there is only soft bone here. So soft bone is very sensitive to pressure. So when you apply pressure in this area, again this bone can resorb much faster. So this small portion of the residual ridge, the superior, the topmost portion of the residual ridge, should be considered as a relief area also. So in maxilla, the relief area will be incisive papilla, mid-palatal raphe, ridge crest, and places of recent extraction where the bone is projecting out and more prominent. Okay. So since now we have outlined the limiting structures and we have also differentiated the relief areas, the other places are obviously going to be supporting areas. So supporting areas, there are three criteria which you have to consider to classify a particular area as a supporting area, a primary supporting area or secondary supporting area. So basically there are three criteria. One of them is bone, and the other one is the type of mucosa, and the third one is the direction of the structure in relation to occlusal forces. So what remains between this and this is the palate. So the palate is not really strictly flat surface, it is a curved surface. So if you see, like, it curves from left side to right side, and it also curves from anterior to posterior. It is almost like a spear, hemisphere. So inside this hemispherical area, you actually have a small portion which is relatively flat, not really very flat, but relatively flat, which is the posterior 2/3 of the hard palate. So the posterior 2/3 of the hard palate, from this side and this side, both of them, they have cortical bone, which is highly resistant to resorption, and also they have a mucosa which is called masticatory mucosa. Masticatory mucosa is a type of mucosa which is present around the teeth. They are usually very tightly attached to the bone underlying beneath them, and they are literally not very mobile. And the keratinization of these mucosa are usually really very prominent, and they can resist a lot of abrasion, pressure, and squeezing, and any kind of trauma. So this mucosa is usually present in the palate and also around the labial and buccal surfaces of the residual ridge. So these type of mucosa are also capable of resisting or taking up or giving good support to the denture during the occlusal loads. So you have this place, the posterior 2/3 of the palate, and then you also have the anterior 1/3 of the palate, which is usually formed, which consists of the rugae. Rugae is not really a structure which is flat. It is more irregular, and also it is slightly angulated in relation to the occlusal forces. So the anterior third of the palate is not really satisfying all the three criteria. It has masticatory mucosa, it has cortical bone, but it is not lying perpendicular to the occlusal forces. So this place will become secondary supporting area, and this place would become a primary supporting area. So apart from this and this, you also have the slopes of the ridge, which is present here, and also on the other sides, on the labial and buccal sides, the slopes of the ridge. The slopes of the ridge also have masticatory mucosa and cortical bone, but again they are not perpendicular to the occlusal forces. So since they are satisfying only two criteria, they have to be considered as a secondary stress bearing area or secondary supporting area. So primary supporting area is a place which can satisfy all the three criteria: cortical bone, masticatory mucosa, which is also called as attached keratinized mucosa, and they should be perpendicular to the occlusal forces. So this is flat, occlusal forces are like this, and there is the occlusal forces. This place can really provide a good support, good vertical support for your denture. That is why this place is considered as primary supporting area. Primary supporting area. All the other places, the anterior part of the palate consisting of the rugae, the slopes of the ridge, the tuberosity, all these places can be considered as a secondary stress bearing area. So this might be a little bit different from the textbook which I shared to you. So normally each textbooks have their own way of explaining the anatomical landmarks. So the method by which I'm explaining is like almost like it's a mix of different techniques from different textbooks, but I think it's more logical in considering the landmarks in the way that I'm explaining now. So this completes the landmarks for the maxilla. So I will just one more time revise the landmarks. So you have limiting structures for the maxilla: labial phenum, labial sulcus, buccal phenum, buccal sulcus, hamular notch, posterior palatal area, hamular notch on the other side, buccal sulcus, buccal phenum, labial sulcus, labial phenum. And inside the limiting structures, you have the supporting structures and relief areas. The relief areas include the incisive papilla, mid-palatal raphe, ridge crest or the crest of the ridge, and then if in case there is any fresh extraction sockets, bony prominences, especially in the canine premolar areas, they also have to be considered as relief areas. The other places are supporting structures. Supporting structures again are primary and secondary based on three criteria: bone, soft tissue or the mucosa, and the direction of the occlusal forces. So only place in the maxilla which satisfies all three criteria is the posterior 2/3 of the palate. All the other places, which include rugae, the slopes of the ridge, tuberosity, slopes of the ridge again on the labial and buccal sides, they satisfy only two criteria. So they should be considered as secondary supporting area. And even when you have undercuts, so when you have a bony prominence, obviously there is an undercut. So undercut is again actually, like, since it is an undercut, the point above the bone, above the undercut would be a prominence, bony prominence. For example, in the canine, if there is a projection of the bone here, there will be an undercut below the bony projection. So obviously the undercut also becomes a relief area, or it might not be able to provide any kind of support because we are going to relieve the bony prominence, and all the portions below the bony prominence until the sulcus is again going to be relief areas. And this is for the maxilla. And for the mandible, again, the only place which remains perpendicular or almost perpendicular is the buccal shelf area. And again, like I explained to you sometimes before, that the buccal shelf area is not really very prominent in all cases. It is prominent only when you have severe to moderate resorption, and only in those cases you will have a flat surface which is lying between the buccal sulcus and ridge crest. So buccal shelf is between ridge crest and the buccal sulcus. So when you have a prominent bone, the buccal shelf actually looks like the slope of the ridge. So there might not be any differentiation between the slope of the ridge and buccal shelf in case of a patient who is having a good bone volume, or when the teeth is recently extracted and the patient did not have any periodontal problem, the bone is not lost too much. In that case, the buccal shelf might be not really very prominent, and it might be like a continuation of the slope of the ridge. So in that case, again, the ridge, the entire ridge becomes supporting area for the mandible. So in the mandible, the supporting area is actually really very limited. There is no such thing like palate in the mandible. So most of the times the support is taken from all of the residual alveolar ridge except for the crest of the ridge. The crest of the ridge again is always having soft bone. So the portions outside the crest of the ridge, the slopes, they will have cortical bone and also attached mucosa. So they can provide some support. So they have to be considered as a supporting area. So in mandible, if you don't have a prominent buccal shelf, which is the primary supporting area, then the slope of the ridge, which would be the secondary supporting area, becomes a primary supporting area. So primary supporting area is an area which is primarily supporting your denture. Basically, when there is occlusal load, the force is transmitted to that particular place. So if there is no buccal shelf, if the buccal shelf is not prominent, obviously the forces are going to get transmitted to the slopes of the ridge. So this makes the slopes of the ridge as primary supporting area. So it depends on case to case. So if you have a good bone, then the entire residual ridge from one side to another side should be considered as a primary supporting area. So obviously when you have a lot of bone, like I told you, the buccal shelf will not be really very prominent. So for this reason, the entire ridge area except for the ridge crest will become a supporting structure. But in this preclinical cast, you don't see any bony prominence. Mostly it is all like smooth sloping surfaces from the crest of the ridge. But normally in patients, you have some bony prominences on the lingual side. Over here, you have a bony prominence, which is the mylohyoid ridge. So the mylohyoid ridge is a small bony projection seen on the lingual side of the residual ridge, and on this ridge, your mylohyoid muscle is attaching. So mylohyoid muscle is like a diaphragm. It's like a membrane that forms the floor of the mouth. It's the bulk of the floor of the mouth. It is attached from the mylohyoid ridge to the occlusal surface. Sorry, the hyoid bone. So this bony prominence is going to be more prominent in some patients. In some patients, it is more rounded and more smooth. That's not a problem. So if you run your finger on the lingual side, and if you feel the mylohyoid ridge is prominent and sharp, that area obviously is not going to be a suitable place where you can transfer the occlusal forces. So that becomes a relief area. And in the anterior lingual side, the midline, you again have two small bony projections called tubercles, genial tubercles, the superior and inferior genial tubercles. So there are two muscles which attach here, geniohyoid and genioglossus. Genioglossus attaches from the superior one and superior tubercle, and geniohyoid attaches from the inferior tubercle. So these places also become more evident and prominent when there is more bone resorption. So this place also becomes a relief area. So relief area in mandible is mylohyoid ridge when it is prominent, genial tubercles in the anterior area if it is prominent, and also the mylohyoid ridge again on the other side. And then the ridge crest, which consists of soft bone, that is also a relief area. So this is on the ridge crest and lingual side. On the buccal side, in the premolar area, you have your mental foramen, which is opening here around this point. So the mental foramen is again something like a foramen, like an incisive foramen in the maxilla. So you have your mental nerve and blood vessels coming out from here. Again, this place is on the slope, so there might not be too much occlusal forces transmitted here if there is good amount of bone. But imagine there is bone resorption and the ridge becomes flatter and flatter. This point comes almost near to the crest of the ridge. So if the patient is having severe bone resorption, and if you think that the mental foramen might be more closer to the ridge crest, then maybe this area also needs some relief from impression pressure. So, and also you have bony prominences in places of canine and premolar when there is recent extraction. Again, you might have some bony prominences where you want to relieve the pressure. So these are the places where you want to relieve pressure during impression making. So in mandible, you'll have mylohyoid ridge as relief area, genial tubercles as relief area, mental foramen as relief area, and then the ridge crest as relief area. And then in any place where you have recent extraction, bony prominences, sockets, all those places also should be considered as relief areas. And the limiting structures or limiting or boundaries include labial frenum, labial sulcus, buccal frenum, buccal sulcus, and then the retromolar pad and the lingual sulcus and lingual frenum. Okay, so these are the basic landmarks, and supporting area is slopes of the ridge. If you have a prominent buccal shelf will be considered as primary supporting area, and slopes of the ridge will become secondary supporting area. If you don't have a prominent buccal shelf, then slope of the ridge becomes primary supporting area. There will be no secondary supporting area. So this is the concept. So whatever place is available and more suitable for applying pressure during occlusal load, that place is called supporting structure or supporting area. And basically we are going to consider three criteria: bone, mucosa or type of mucosa, and the direction of the structure in relation to occlusal forces. So buccal shelf, when it is really very prominent, it is flat like this, and then the occlusal force is up from here. It is usually very perpendicular, and also it has attachments, thick muscular attachments over this place. So it is usually capable of resisting a lot of occlusal forces and loads. That is why it will be considered as primary supporting area, because it is satisfying all three criteria. But in other places, they are not perpendicular to the occlusal forces, although they have attached mucosa and cortical bone. They are not perpendicular to the occlusal force, so they have to be considered as secondary stress bearing area. But in the absence of or less prominent buccal shelf area, when buccal shelf area is not prominent, then slopes of the ridge becomes primary supporting area. Okay, this completes the relief areas and other things. So there are some landmarks which can be a little bit more of importance. For example, the retromolar pad. The retromolar pad is actually a limiting structure. It is the posterior extent of your complete denture, of the mandibular denture. It has some other significance. For example, like when the retromolar pad is at this level, normally in patients with teeth, the occlusal surface of the teeth is present around about 2/3 the height of the retromolar pad. So imagine you have the retromolar pad, you are outlining the retromolar pad and you are dividing it into 3 equal halves, 3 equal parts, lower third, middle third and upper third. So this becomes a 2/3. So usually the natural teeth occlusal surface is present at this level. So this is the significance of retromolar pad. So retromolar pad helps in identifying the occlusal plane of the posterior teeth. So this is one of the specific landmark, some unique function or significance of this landmark. And rest of them actually in mandible do not have too much of significance. So retromolar pad helps us in locating the occlusal plane for the posterior teeth. This is the use of retromolar pad. And in maxilla, you have tuberosities. So tuberosities also help in limiting the occlusal surface for the posterior teeth. For example, your canine is here, the other canine is here. So the anterior teeth is arranged from this point to this point, and then in the posterior, you need to have some point where you want to stop the teeth or the occlusal surface. So this is the point which is considered as that point where you want to stop the occlusal surface. This is because when your upper teeth and lower teeth are against each other like this, immediately below the tuberosity you have retromolar pad. So retromolar pad is like, it's a sloping structure, it goes up like this, it's a sloping structure. So when there is a teeth which is present on the tuberosity, on the maxilla, if you place a teeth on the tuberosity, you might also place a teeth on the retromolar pad. So what happens when there is occlusal force, and if the bone is not really very prominent, there is severe resorption and there is occlusal force on the retromolar pad area, the denture starts sliding forward like this. So this creates a lot of instability for your denture. So this is the reason why we follow the tuberosity and we use the anterior of the tuberosity as the point where we want to stop the posterior teeth. So that's the significance of retromolar pad. And mid-palatal raphe is like a structure which can be used to trace the midline. So mid-palatal raphe is usually present along the midline of the palate. So this can be used as a structure which can be a reference for the midline of the denture. And the incisor papilla normally lies, the center of the incisor papilla normally lies about 8 to 10 millimeters in front of the behind the incisal edge. So this is one of the important average location position for your incisor teeth. So incisor papilla can be used to locate the position of the incisor teeth. And then you have something called as canine papilla canine line. We have discussed it in the lectures. So you draw a line which is perpendicular to the midline following the mid-palatal raphe, and then you have a line which is called canine papilla canine line. So this canine papilla canine line is again something which can give you average location of your canines, cusp tip of the canines. So it is believed that like in a dental arch, incisor papilla is here, the canine is here, the canine is here, and when you draw a line between line connecting cusp tip to cusp tip of canines, canine papilla, canine line. So this line will approximately give the location of the cusp tip of the canines. So this landmark or this idea is derived from the patient with teeth. So this can be a point of reference which can be used for arranging your canine teeth. And then you have this distance, this 8 to 10 millimeter distance between the incisal edge and the center of the papilla. So using these points, you can perfectly arrange the anterior teeth in approximately natural position. So incisive papilla helps in locating the incisors, canine papilla, canine line helps in locating the canines, and tuberosity helps in locating the posterior point of the occlusal surface. And the mid-palatal raphe helps in identifying the midline for your denture. So basically that is it. And if you have any more doubts, like you can send a personal message on Telegram, and I'll try to help as much as possible.